I'm so fortunate today to be here with the Milton Packer, who has got the clinical trial being presented at the American Heart Association, that I believe is going to change practice, is going to change the way people think, and of course has been done in Milton Packer style as just an extraordinary study. But welcome, Milton. This is just intended to have a little time for us to have a conversation about this masterpiece and to hear like where did it start, how did you do it, and
Oh,
what should everyone know about it?
Harlan, it's a delight to be with you. It's a great story. It's a really, really great story, and it's a very special trial. I must say that um, there is a unique story to this trial, well, compared to other trials. So we can talk about this. This will be a lot of fun.
Well, let's start there. What is the story of this trial?
Well, this trial is with a is in a disease, a subphenotype of heart failure called heart failure with preserved ejection fraction with obesity. And it probably comprises about two-thirds of patients with HFpEF. It's a substantial proportion. And we think there's a lot of great data to support it.
Who's we?
We, those who think about HFpEF and think about how does obesity cause heart failure? How does that happen? Well, I'll give you one hypothesis.
Can I jump in one
Sure,
question this first? So, as I learned about HFpEF, all this time, there are all these kind of questions. How do you determine who's got HFpEF and
sure.
at the phenotype? But until recently, I hadn't realized how much the condition was really associated with obesity. And I
Yes.
hadn't been hearing a lot. Now I'm just talking over the decades, right? I hadn't been hearing people talk about obesity related HFpEF. But in recent years, of course, starting with STEP HF, people are starting to talk about this. Where did that even come from? Because who made that observation that there was
Well,
this association?
so that association has been made for decades. People who were interested in HFpEF noticed that patients who came to clinic
But like
had,
most Americans, there's obesity. I mean,
yeah, and to a significant degree, because so many people with obesity go to cardiologists for
yeah.
cardiovascular problems, it probably didn't get a special link, but it is a really special link. The data to support this is substantial. First of all, think about it this way: obesity is the pinnacle of the interface. Obesity-related HFpEF is the pinnacle of the interface of angry adipocytes. Adipocytes who are angry, I say who,
Inflamed.
I just humanized the adipocytes. Uh, Adipocytes who became expanded and changed their biology because they grew and grew, and in doing so, they did two things. They secreted substances that were anti-natriuretic, so they were sodium retentive, and they secreted substances that were pro-inflammatory. Now, just think about it. This is unbelievable. This is really amazing. The anti-natriuretic substances expanded plasma volume, and the pro-inflammatory substances, especially around the heart, visceral fat around the heart, cause myocardial inflammation and fibrosis. So you increased filling of the left ventricle because of the hypervolemic state, but the left ventricle couldn't distend because it was fibrotic. And that is HFpEF.
That's the combination that produced it. Yeah.
And that is the combination of two physiological factors that drive HFpEF, and they're both initiated, ignited by expanded adipocytes. So, the adipocytes that matter here are in visceral fat, not subcutaneous fat. It's the best index to follow here is not body mass index. Body mass index effects include skeletal muscle, bone. It's very
Fluid
geographic.
retention could be part of it, right?
Yeah, but and food retention can be part of it. So the real metric is waist to height ratio. People have been talking about it for a long time. There's a lot of interest, but it really reflects visceral adiposity. And if you measure waist to height ratio, it is the best predictor of subsequent development of HFpEF.
Hmm.
And it is epidemic in the population, of course, particularly in the United States, but worldwide. And the
And so by saying that, you really are saying the central obesity, of course, because people can have different types of places where they're placing the fat, right? So when
yeah,
you're saying waist to height, it really is also accentuating the central obesity.
it's central obesity. It's visceral adiposity, mesenteric
Yeah,
is a
yeah.
large part of it. But the visceral depot that I care about is the one around the heart, because when you expand epicardial fat, there's no fascial plane between the
Hmm.
epicardial adipocytes and the
And
cardiomyocytes.
so that's why you get the myocardial inflammation because they're right
Exactly.
next to each other.
Exactly.
Uh,
Exactly. So it's really a wonderful hypothesis, and we have been over the past many years, we've been sort of developing drugs that don't really address the problem. Let me give you an example. Um, Angiotensin receptor neprilysin inhibitors have an effect in a meaningful number of people with what we call HFpEF, but it's generally in the range closer to HFrEF than in HFpEF. There's data now that mineralocorticoid receptor antagonists might be useful in HFpEF, but one thing that's really interesting is that one of the substances that adipocytes make to cause hypervolemia and fibrosis is aldosterone. But it's not the only one. So, mineralocorticoid receptor antagonists take care of one thing that adipocytes make, but not all the things that adipocytes make. And SGLT2 inhibitors also shrink adipocytes. And that's nice, but they don't have a major effect to do that. Um, the change in visceral
I don't think
fat
I knew
with
that they shrunk adipocytes. When you say shrinking them, is it that they actually they're essentially their
they
size
cause a
and
starvation state
yeah,
because of glucose loss.
yeah, yeah.
And the body basically mobilizes its fat stores and they shrink, but it's a reasonably modest effect. It's a modest effect, but it's definitely present. So, but if you really wearily want to shrink adipocytes, you're going to have to signal through the GLP-1 receptor because that really mutes adipocyte hypertrophy and inflammation. And it changes the biology of adipocytes so they become more normal. So there are, two major drugs that are now approved for the treatment of obesity, also the treatment of diabetes, which is semaglutide and tirzepatide. Semaglutide is selective for GLP-1, and tirzepatide signals not only through GLP-1, but also through GIP, which is a related incretin. And as a result of that, it causes more weight loss than semaglutide in clinical trials. And so we were really interested in seeing what tirzepatide would do to patients with HFpEF and obesity.
So who's we again in this one?
Well, we here is the sponsor of tirzepatide, which is Lilly. And Lilly put together a wonderful steering committee and asked me to be chair of that committee, and initially proposed a straightforward trial of patients with HFpEF and obesity that would focus on exercise tolerance for 52 weeks.
So now you're transitioning into the story of Summit. So this Summit, well, I'm just for the listeners, just to now we've talked about the rationale, but now you're telling us a little bit about like, okay, so Lilly had an idea, a very straightforward trial, exercise, and then what happened?
Exercise tolerance, 6-minute walk, and to take patients who would fulfill criteria for HFpEF and obesity and treat them for 52 weeks, tirzepatide versus placebo. And we said, well, that's nice, but we want to do an outcomes trial. And they said, oh, gee, an outcomes trial is a very major investment. Could you work with what we have and make it as good as it can be? And we said, okay, we're going to do that. Let us develop a composite of death, worsening heart failure events, KCCQ, and 6-minute walk. And let us not just treat patients for 52 weeks, but let us treat patients for years. And Lilly said, okay, well, how are you going to do this? We created a hierarchical composite. We extended the trial to go on for years. And we started to recruit into the trial. Trial was very straightforward.
When did recruitment start?
2021.
Okay. After the pandemic, I mean, but still in the pandemic, so.
Right. But one thing we really wanted to do was focus on worsening heart failure events. That was very, very important. So to do that, we had to enrich our patient population. Very, very important. So the patients who came into the trial were very different than patients recruited in other HFpEF trials with obesity. Two differences, very, very important. First difference, we didn't have a NT-proBNP criteria. And the reason is patients with obesity have very low N-terminal proBNPs, even if they have high filling pressures. Well, if you only recruit people who have high
and by the way, why is that? I know that that's observed phenomenon.
Oh my God.
Okay, maybe I shouldn't have.
People have been struggling to explain that for a long time. Harlan, I can give you stories, but in all honesty, I don't think I can give you a good explanation.
Okay, well, let me keep you on. But I think it's good for listeners to know that this is true, but we're still not sure exactly why.
Right. About 40% of patients with HFpEF and obesity have N-terminal proBNPs that are very unimpressive. About 100. Most people wouldn't.
So even though they can have high filling pressures, it's not reflected.
They have heart failure, they're very sick, they can't walk, and they have N-terminal proBNPs, which are really in almost the normal range, or at least the normal range for 8.
Yeah.
So, but here's the thing that was very important. We wanted to recruit patients who would have events. So we said they had to have had a hospitalization for heart failure recently, or poor renal function, low eGFR, and they had to have an impaired exercise tolerance on 6-minute walk, and they had to have a low KCCQ. Every patient had a KCCQ less than 80.
Less than 80. And just so we're clear for listeners, when you say worsening events, what do you mean by those events?
So the worsening event,
Hospitalizations.
right? So worsening event that we defined in this trial was worsening symptoms, worsening exacerbation of symptoms that required a heart failure intervention, which was either hospitalization, urgent intravenous therapy, or oral diuretic intensification, one of those three.
Mhm.
Uh, and we that was the definition of an event, and it was combined with cardiovascular death. Everything
And
was
were you concerned
adjudicated.
with the diuretic intensification because
Yes,
it's
yes, we
kind of
were.
unblinded and it's in some ways just a judgment call for many people.
We were very cautious about that, and we worried about it. We thought that the strongest part of the worsening heart failure metric was
Yeah,
hospitalizations and urgent IV therapy.
yeah,
Harlan, we really thought about this. And so we specified, and we had lots of discussions with FDA. We specified that we would do the analysis with and without oral diuretic
yeah,
intensification included as an event.
yeah. And
So,
and I'm
yeah.
curious how many people you had to screen to get an eligible person, given you've got these criteria.
Well, we screened 14, a little bit over 1,400 patients. We randomized 731
Well, that's pretty
patients.
good. That's not much of a loss actually through that. So,
It's not bad. We typically screen about twice as many patients as we randomize in a given trial. Sometimes the ratios are a little bit, the losses,
mhm.
the screening loss is a little bit greater.
And how
Uh,
many sites did you have across how many countries?
129 sites
Oh my
across
gosh,
9 countries.
9 countries. Huh.
Right.
That's
And
something to
yeah.
manage. Yeah.
Yeah, so it was really interesting. The trial recruited over was continuing to recruit. And then I attended the presentation of the STEP HFpEF trial at the European Society of Cardiology meeting in August of 2023. Uh, and they reported a reduction in worsening heart failure events with a hazard ratio of 0.08.
Pretty.
92% reduction risk. It was only based on 13 events. But gee, I was pretty impressed. And so I went back to Lily and I said, instead of making cardiovascular death and worsening heart failure events as part of a hierarchical composite, I want to separate it out as a primary endpoint, as a standalone primary endpoint, because I think our effect size is going to be bigger than we expected. We originally expected an effect size of 20 to 30% reduction, but STEP HFpEF was reporting a 90% reduction. Well, we knew that wasn't true, but we thought, well, we could probably have enough events in the trial as it was designed, because it was such an enriched patient population, that we would be able to detect a 40 or 50% reduction in risk, and we would have enough power to do that. Um, so, the reason that we do trials of 6,000 patients in heart failure is because we expect an effect size of that's this small, like 13%, 15%. If you expect an effect size of 40 or 50%, you only need about 700, 800 patients.
Yeah.
So in a blinded manner, after consultation with FDA, entirely related to information external to the trial, we revised the primary endpoint so that cardiovascular death and worsening heart failure events was a primary endpoint with an alpha of 0.04. And KCCQ had the remaining alpha of 0.01. And those were our two co-primary endpoints. We had 6-minute walk test and body weight and high sensitivity CRP as secondary endpoints that were alpha protected.
And I just want to emphasize the point you made, which is sometimes listeners may hear people talk about changing endpoints and say that's a red flag. You know what? Why are people changing endpoints midstream? You changed endpoints because of information that was external to the trial.
External to the trial.
Nothing that you saw about the results, nothing about anything you saw in the trial.
We didn't know what the event rates were. I mean, we projected event rate, but we didn't know what the event rates were.
And so in this case, it still represents, for people listening, a best practice because it's not being biased by any early information. In fact, it's just a matter of we would be foolish not to take advantage of the fact that we would know something from someone else. Let's make this now a stronger trial, and we haven't seen any of the results, so we don't.
That's it. That's exactly right. And Harlan, you said it perfectly. It would be foolish to ignore something that we had learned from the experience of others treating the same disease with a drug that interacted with GLP-1. I mean, if we ignored that, we would be missing an important opportunity. There's no bias. It's all external data. And we went to FDA. We had great discussions. They agreed with the revision of the endpoints. And the trial continued until the last patient had been followed for 1 year.
So now you've whet our appetites. Of course, before the HA, we already knew that this had been. I'm loath to use these words positive and negative, but let me just say it found benefit. I say that because negative makes it sound like I think negative trials, meaning they don't find a difference.
Yeah,
it's not important as those that find differences. But when you find a difference, it feels different. And Lilly announced this because they need to make certain disclosures with a publicly traded company, but didn't give us much information. But now at the HA, you were finally able to present publicly and simultaneously publish about it. And tell us a little bit about it.
So we found the trial closed, and we found some really, really fascinating results. First of all,
I feel like I want to do the drum roll, but most people will have heard the results by now by the time they see the
video. I mean, but what people may not know is the depth of the results. So the primary endpoint, cardiovascular death and worsening heart failure events, was reduced by 38% with a p-value of 0.026, which was less than the alpha that was assigned.
So almost a 40% reduction. I mean, you didn't get the 90%, but a 40% reduction.
And we had projected a 40 to 50% reduction because we just took what STEP HFpEF found and we cut it in half.
And they had 13 events. And
they had 13.
You had how many events?
92.
92.
So now, if you took that primary endpoint and you took out the worsening heart failure events treated with oral diuretic intensification, so it's just worsening heart failure, hospitalization, or urgent IV therapy, and you redid the primary endpoint, it came out with a slightly smaller hazard ratio, 0.57, with a p-value of 0.03. So the diuretic,
Still directionally the same,
it's
ballpark the same.
it's the same with the same p-value. It's the same result. The oral diuretic did not
Was
drive
not
the result.
driving the result, was not driving the result.
What was driving the result was hospitalizations for heart failure. Hospitalizations for heart failure, and they were reduced by 56%
Wow.
in the
Wow.
with a p-value of 0.018.
Yeah.
So it was a very clear and impressive result. But it only starts there. KCCQ significantly improved intention to treat, nearly 7-point difference. I hate reporting mean values for KCCQ. But when we did thresholds of KCCQ, the likelihood of an improvement by 5 points, 10 points, 15 points, 20 points, it was twice as likely to improve with tirzepatide than placebo. Now, for most drugs that we have for HFpEF, when you look at the threshold changes in KCCQ, you get odds ratios of 1.1, 1.15. We were finding odds ratios 1.8, 1.9, 2.1 across the board.
So let me just ask you a couple quick questions. One, what was the difference in weight loss between the two groups? Well,
11,
starting off, like, I know you don't like BMI, but what was the average BMI in the groups?
38.
38. Just because people are used to those numbers, they're not as used to the waist to height.
So the average BMI, here's some of the demographics because it's really relevant. Average BMI was 38. The average KCCQ, remember we enriched for that, was 53, really low. The average 6-minute walk distance was 300 meters, also really low. Average eGFR was 61. So and half of the patients had been hospitalized for heart failure within the past 12 months. So we really had an enriched patient population.
And then getting back to what was the comparison on weight loss?
So 11.9% difference between the two groups. That's the between group difference.
Yeah, that's between groups. And another question I have for you is, because we've seen this in some of the other studies, we saw this in SELECT, for example, on secondary prevention. Was the separation of curves for risk, did it occur early? Was it preceding some of the weight loss, or when did it occur?
So the weight changes,
the
weight changes is just an unbelievable, interesting result. The weight changes were apparent after 4 weeks.
Mm-hmm.
Now, tirzepatide was started at a low dose and then increased.
Right.
And it reached its peak dose at about 20 weeks after randomization. 20 weeks after randomization, which is about when body weight reduction reached its maximum. So that's not too surprising. This is very similar to what's been seen in every.
And what did you escalate to? 10 or 15 or
15?
15.
15 milligrams subcutaneously weekly.
Okay.
And so it was really interesting. So weight went down after 4 weeks, continued to go down. The effect on high sensitivity CRP didn't change until 24 weeks. We measured it at 12. It had not gone down. The amount of weight loss to get a reduction in high sensitivity CRP, we got our maximum effect at 52 weeks, which is when we essentially, around 24, 52 weeks, we were getting our maximal change in weight. But it was the event curves were pretty much on top of each other for the first 18 weeks of randomization, and then dramatically changed. So the events follow the changes in high sensitivity CRP.
And what was the mean CRP at baseline again?
5.7.
So high, yeah, high.
Really high.
Yeah.
Yes.
No, that's
Really high.
fascinating. You know, but according to what you were explaining this in the beginning, it
Yeah.
makes sense, because if this is actually inflammation and fibrosis, and this
That's
is
exactly right.
change the dynamic overnight, and it's different than in secondary prevention where you're trying to maybe prevent plaque rupture or thrombotic events. This is something where there needs going to need to be structural change for there to be actually improvement.
And in fact, in a paper that has just been published in JACC.
Now there we go. Now we're finally where I want to go. The paper.
Yeah, we found those structural changes. So Chris Kramer led a prospective blinded CMR sub-study, cardiac magnetic resonance imaging. It was before and after therapy, 52 weeks of therapy, placebo versus tirzepatide. It was all of the images were blindly read without knowledge of the sequence and without knowledge that it was in the same patients. That is really the right way to read these images. So they're essentially the person reading the images doesn't even know that these are paired tests in the same individual. So, and in the past, when semaglutide looked at structure and function, it did it by echo. And it's not a terribly sensitive approach. So CMR is much, much better for two things that echo can't measure. It's much better for left ventricular mass, and it's much better for visceral fat around the heart. And so what we found was a statistically significant reduction in both left ventricular mass and visceral fat around the heart, dramatic reduction in visceral fat around the heart. And the two appear to be correlated. Now, here's the thing that's so really interesting. When you say there's a reduction in mass around the LV mass, the first thing most cardiologists think of is, oh, this must be regression of cardiomyocyte hypertrophy. But remember, most of the mass of the heart is not cardiomyocytes. Cardiomyocytes are only about 30–40% of the myocardium. Most of the myocardium represents interstitial tissues, fibroblast, vasculature, a whole host of different cell types. So when you see a reduction in LV mass in a state that is characterized by fibrosis, the thing that you think of is that there is regression of fibrosis. Now, most cardiologists think that fibrosis is this irreversible event. The fibroblasts grow in, they deposit collagen.
It's scarring, right?
And but it's a dynamic process.
Yeah.
Fibroblasts go back and forth. The collagen is reabsorbed, it's resecreted. And so the there is regression of fibrosis if you can intervene. And I think that is what's responsible for the reduction in LV mass. So the JACC paper on Summit is the first paper to show that this kind of therapy has an effect on both LV mass and visceral fat, and that the two appear to be related
That's
to
something.
each other.
That's a
It's
terrific study.
really, it's
Yeah.
really, really interesting.
Well, but
Now,
by the way, this is why I call these, it may be mediated through the weight loss, but these are heart healthy drugs. These are right. These are restoring the
well,
health.
I mean, they do have a direct effects on cardiomyocytes, but I don't, I really think that their effects are on angry adipocytes that happen to live right next to cardiomyocytes, and they make the cardiomyocytes very miserable. And the way that you make cardiomyocytes happier is you get rid of the stimulus, which is making them miserable, which
Well,
is the
th-
shrinking the adipocytes.
this is fast. Well, let's bring this home because we've been talking for a bit, and I know
Uh,
people have enjoyed this.
Let me
What are the
just,
implications of Summit? What do you think are the implications?
well, if I could, I just want to list for sake of completeness, just list a couple more
Oh
of
yeah,
our,
please, of course.
if I could.
Yeah.
First of all, not just an improvement in KCCQ, but also an improvement in 6-minute walk distance, P less than 0.001, an improvement in EQ,
Meaningful improvements, not just statistical improvements.
meaningful improvements, an improvement in health quality of life using the EQ5D5L, which, by the way, almost never is affected by a heart failure therapy because it's a really tough
It's
index.
a general
It's a
evaluation.
general index. So significantly improved at 24 and 52 weeks. Significant improvement in New York Heart Functional Class at 24 and 52 weeks. Um, a significant reduction in the need for heart failure medication and a decreased need for heart failure intensification. So we saw all of these improvements in patients on tirzepatide, even though they were getting less heart failure drugs than the patients on placebo.
And
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 I'm sorry,
you had a substantial proportion of men and women, and
oh, majority were women.
majority were women. And what about racial, ethnic?
Uh, a large population of patients, Hispanic patients, not a large number of African Americans. We represented a small group of patients, but that was largely because most of the recruitment occurred outside of the United
Mm,
States.
mm,
Um, there, two more things: a reduction in troponins.
mm,
And most really interesting and significant improvement in EGFR.
mm, mm.
And it's the STEP HFpEF trial
Not
didn't
just a slowing of the decline,
a
of
significant improvement.
improvement. Wow.
At sig-
That may be the most impressive and surprising thing. I didn't expect that.
it has been reported in other trials, but it was not measured in STEP HFpEF, so they couldn't report it.
Oh, wow.
So there is a broad-based benefit on everything related to heart failure, everything related to heart failure, uh, with structure function relationships and a reduction in cardiac injury, a reduction in LV mass, an improvement in kidney function.
What a
God, it
huge,
was.
what a huge, this just must feel good when the results started coming in like
It,
this.
it, we kept on looking at this and we kept on saying, gee, that the framework we had for this disease, the way we thought about this disease, is it possible that we were right? Is it you when you do a clinical trial, um, you're happy if you can confirm your hypothesis, but typically you don't see everything line up so well. And particularly, you don't see everything line up so well in a trial of only 731 patients. By the way, when we did all of our pre-specified subgroup analyses, not a single baseline variable was an effect modifier.
Wow.
Every single subgroup lined up for both primary endpoints. So we don't see trials like this very often.
Wow.
Um,
Just
we
so
were
sweet to
very,
get this, huh? So sweet.
it's really, really, it was, we were very, very
So,
happy.
so, so, so I want to get to these implications though, because when I'm
Sure.
listening to you, I'm thinking, I think this evidence is strong enough to say every single person in this situation should have access to this medication. I mean, do we need another trial to confirm this? Do you think this is enough? Is this going to be a 1A recommendation? Where do you think it's going to land?
Well, it's really interesting. The, what's really interesting is how frequent heart failure events were in these patients. 15% of patients in the placebo group had a heart failure event during the course of the trial. Well, that's pretty meaningful risk. That's a lot higher than what we see even with class 2 heart failure and HFrEF. So, if you have a patient who has HFpEF and obesity, and they have a meaningful degree of symptoms and functional limitation, remember that was the group of patients we enrolled. They're at high risk of worsening heart failure events and a drug like tirzepatide not only reduces the risk of those events, but it improves symptoms, it improves exercise capacity, it improves quality of life, it improves kidney function. And we have all of these mechanistic insights that show that the heart's better, visceral fat disappears, and cardiac injury goes down.
By the way, did you measure anything related to depression or mood, or because I would expect that it may actually their mental state might be improving in all of this, and it's
I, I,
social interactions would be heightened. I mean, you didn't, not that you measured a ton, but I'm just thinking this must be game changing for those people who had this benefit.
well, I think that that is likely to be true. We did not measure anything related to social interactions or depression
I mean, you've
scores.
taken people who are debilitated and
Yes.
now you've given them a new lease on life, really.
Substantial effects. Is this, is this going to change clinical practice? I, Harlan, the answer has to be yes, because what else do you need to see? Remember, it's not, we saw these very impressive effects with tirzepatide, but now you put this side by side with the effects with semaglutide in step HFpEF, and you see a consistency now across three different trials. Step HFpEF stopped at 52 weeks. We kept on going. We had a more impaired
What was the
population.
median follow-up? For a moment, I thought you
Uh,
stopped at a year, but that was the
100,
shortest time was a year. So you had men, people out longer.
104 weeks was the median follow-up. Maximal follow-up was 3 years.
Wow. No.
So it is one of the very longer GLP-1 receptor agonist trials. So it's really quite nice. I mean, if I were a physician and a patient had HFpEF with obesity, this would have a major impact on them. But here's the challenge. Harlan, the challenge is getting physicians to recognize HFpEF in patients who are impaired and who have a body mass index of 30 or greater. Because most physicians, when they see a patient who has obesity, and if they are impaired and they can't walk and they're symptomatic, will say, oh, it's because you have obesity. They won't even work the patient up for HFpEF. By the way, that's not so easy to do. N-terminal proBNP you can measure, but it's not really impressive. You can get an echo and you say, oh, I'm going to look for diastolic filling abnormalities, but that's that's a very operator-dependent measurement, which is not terribly consistent. You can look at left atrial size, by the way. I happen to think that's what you should be looking at on an echo. But a lot of people will say, well, the left atrial size is big, and it's not big if I correct for body surface area, which is very large. So making the diagnosis of HFpEF here is really hard. The gold standard for doing that is right heart catheterization during exercise. Well, most medical institutions are not set up to do that. But that is the way you make the diagnosis. So the challenge here is not, I think, persuading physicians that the drug works. The challenge is identifying patients in the clinical community who have the diagnosis.
Hmm.
That is the real challenge to cardiologists. And it's not an easy challenge to meet. It requires a re-education process. And in all honesty, I think that outreach to patients here is so important.
Hmm.
Patient awareness
That's right.
can drive this,
Yeah.
probably more here than in most diseases that we treat as cardiologists.
Hmm.
So I think there's a lot of education that needs to be done. The data are really, really, really nice. The other thing that's wonderful is we also had biobanking in this
Oh,
trial.
wow.
So able to
Lots to
measure
learn. Yeah.
well, be able to measure pro-inflammatory mediators, aldosterone, all of the
How
parts.
many times did you get samples?
We got samples at baseline, 24 and 52 weeks.
That's fantastic.
Yeah,
Well,
it's
well,
great.
well, Milton, let me just congratulate you. This is a landmark study. That this is going to change practice. It will change lives. Uh, just a wonderful, wonderful job. It was great to hear the story. I mean, if you guys hadn't leaned in, and when I say guys, I mean men and women, hadn't leaned in to say there's much more to learn here, and you hadn't been agile with the new information, you wouldn't have what you have here. And
Well, but
congratulations.
I think that's a fair statement, but we also had to have a sponsor who wanted to listen and wanted to wanted to work with us to make the trial as good as it could possibly be. Um, Steering committees don't have authority. We give advice, but we don't write checks for the trial. So if a sponsor is not receptive and if they don't want to reach for the stars, then we would never have a trial like this.
Well, anyway, lots of people to congratulate, lots to learn. I push people to the NEJM paper, to the JACC paper. There will be many others to come. And thank you so much, Milton, for taking the time with us today.
Harlan, it's always a delight. Thank you so much.
All right.